Hi, I'm Phil Perazio. You may have been recently diagnosed with testicular cancer or are worried about testicular cancer. This short video is designed to give you some of the basics around that diagnosis. So, about 9,000 men per year in the United States are diagnosed with testicular cancer, making it a relatively rare cancer. However, the cure rate is greater than 95% for all of those men who are initially diagnosed with cancer. That means there are hundreds of thousands of survivors out there and men who've either been treated for, cured of, or been scared about the diagnosis of a testicular cancer. So you are not alone if you're going through this. Testicular cancer can affect men of any age, although we typically see it or we typically ascribe it to men 15 to 45 after puberty. We can see testicular cancers in infants all the way up to men in their 90s. And this is pictures of some of the celebrities, sports icons, entertainment celebrities, musicians, actors who were diagnosed, treated for testicular cancer, some of them more well-known than others. The testicles have two major functions. One is they produce testosterone, the male hormone that gives us beards and erections. The other function is to produce sperm. Testicular cancers actually form from those cells that develop into sperm. Those are called germ cells. There are some really rare forms of testicular cancer called stromal tumors that develop from the Leydig cells that produce testosterone, or Sertoli cells that support the development of germ cells or sperm cells. But this is not usually what we're talking about when we're talking about testicular cancer. The two most common forms of testicular cancer are called seminoma and non-seminoma. And non-seminoma comes in about 4 different flavors called embryonal, yolk sac, choriocarcinoma, or teratoma. The main distinctions are that seminoma in general is slow growing or slower growing, although there are some times when it can grow pretty quickly too, and it is exquisitely responsive to chemotherapy. So for treatment of testicular seminomas, we're often talking about surveillance or treatment with chemotherapy and occasionally radiation. Non-seminomas come in a variety of flavors, as I already described. Some of those are less resistant to chemo or more resistant to chemotherapy, less responsive to that, particularly teratoma. And so when we talk about the management of non-seminomatous germ cell tumors, we're often talking about chemotherapy and or surgery to treat this disease. In general, testicular cancer comes in 3 stages. Stage 1 is confined to the testicle. Cure rates 99% or better for men who have cancer just in the testicle. Stage 2 is testicular cancer confined to what are called the retroperitoneal lymph nodes. So the testicles actually form near the kidneys in the developing embryo. In about the 8th month of your mother's pregnancy, testicles descend to their normal resting place in the scrotum. So their blood supply, their lymphatic drainage, their muscles, and their nerves actually all originate near the kidneys. So the first place testicular cancer spreads are to lymph nodes around the aorta and vena cava, the biggest artery and vein in the body, and near the kidneys. Men who have testicular cancer in the lymph nodes have a 90% or greater cure rate. And finally, stage 3 testicular cancer is cancer that has spread beyond those lymph nodes, what we call distant metastasis. Commonly, this is the lungs, but it can be in lymph nodes outside of the retroperitoneum. It could be in the brain. It could even be in bone. So testicular cancer can spread to a variety of organs, but even in its most advanced states, the cure rate is still 70% or greater for the majority of men. Testicular stage 1S is a rare form of testicular cancer, pretty uncommon. This is when testicular cancer is only found in the testicle and the testicle is removed, but tumor markers remain elevated, indicating that there's cancer somewhere else in the body. Now, when we think about treatment options, we've got, in general, 4 treatment options for testicular cancer. Surveillance refers to watching early stage disease, typically stage 1 seminomas or non-seminomas. The benefit of surveillance is that it avoids unnecessary treatment, but it certainly involves serial imaging and tumor marker checks to make sure that this cancer stays away. Recurrences are most often treated with chemotherapy, although some patients certainly can be eligible for surgery. Chemotherapy is available to both men with seminoma and non-seminoma. It often has the highest cure rate as a single modality and the lowest relapse rate. It is often, we talk about this as our one and done treatment. If you want to be done with your testicular cancer, chemotherapy is often the way to go. It can be either be given as carboplatin single agent therapy for men with early stage seminoma or multi-agent therapy, typically either what's called BEP or EP for men with seminoma or non-seminoma that is outside of the testicle. Fortunately, chemotherapy has both short and long-term toxicities. We're all well aware of the short-term toxicities. You can lose your hair, nausea, vomiting, fatigue, very common. Long-term toxicities are associated with developing second cancers as you get older. For some men, it can predispose them to early heart disease and can affect a variety of our other organ systems that you need to be aware of. Radiation therapy is being less and less used in the United States, but this is an excellent treatment for men with stage 2 seminoma. It has a very high cure rate. Cancers can still recur, what's called out of the field. So when you radiate an area, cancer can, if it's living outside of that area, it will still persist. Once again, we know that radiation therapy has short-term toxicities, most pretty manageable. It's the long-term toxicities that has made it less desirable in the United States. We know 20 to 30 years after a dose of radiation therapy, it can predispose men to certain issues related to second cancers or, once again, atherosclerotic or plaque disease in their arteries and vessels. And then the last management option is something called RPLND or retroperitoneal lymph node dissection. This is surgery typically for non-seminomatous germ cell tumors, or there's some new data that says RPLND might be a good option for patients with seminoma. RPLND has an excellent cure rate, particularly for men with teratoma in whom are not going to respond to chemotherapy. There are very few long-term toxicities with RPLND, but the risks are really high around the time of surgery. We're operating on the aorta and the vena cava. These are some of the biggest blood vessels in the body. It could lead to bleeding that requires a blood transfusion. It could lead to lymphatic leaks, something called cholecystitis, which is a really troublesome complication after surgery. And it can affect our ability to ejaculate or have children in a natural fashion. And so when we think about stage 1 disease, we know this is confined to the testicle. Our treatment goals are really to avoid treatment, minimize long-term toxicities. And so we're focused on surveillance in this setting. And here's the data. And so when I talk to men about stage 1 disease, the bad analogy is that all roads lead to Rome. And here's a artist depiction of all of the major highways in Europe leading to Rome, which is the green dot down at the bottom of the screen, meaning 99 to 100% of men diagnosed with stage 1 disease are cured of their cancer. You pick a road to set out on. This may be surveillance, this may be chemotherapy. You recognize you may get knocked off that road, but you're going to end up at a cure almost no matter what you choose. And here's the data. So we know for stage 1 testicular cancer, the cure rates, as I said, greater than 99% for both seminoma and non-seminoma. What we really worry about is the recurrence or the risk of this cancer coming back, typically within the first 2 years, can be as long as 4 years. So for men with what we call low-risk stage 1 disease, this is anybody with seminoma or what's called a 1A non-seminoma, meaning there's no lymphovascular invasion on your orchiectomy specimen. Surveillance is really preferred because only 10 to 15% of men will have a recurrence. That means greater than 85% of men are cured just by orchiectomy and by watching them closely. Certainly some men may consider chemotherapy or radiation therapy in the setting of seminoma. We really try and stay away from RPLNDs in the setting of stage 1A non-seminomas. For men with what we call high-risk stage 1 disease, these are non-seminomatous germ cell tumors that demonstrate lymphovascular invasion under the microscope. 40 to 60% of those men will have cancer recurrence within the first 2 years of diagnosis. So the balance between surveillance and recurrence and either getting upfront chemotherapy or an upfront RPLND is a much more personalized decision and really warrants strong conversation with your physician. In stage 2 disease, remember, once again, this is cancer limited to the retroperitoneum. We know you're going to need additional therapy to get to cure. So we want to limit those treatments, get to cure with as few treatments as possible. That way we minimize the toxicities and really prioritize survivorship and your long-term goals, remembering that we have a greater than 90% cure rate in this setting. Here's the data here. Once again, whether it's seminoma or non-seminoma, remember the cure rate is greater than 90%. We know that for stage 2A disease, this is small lymph nodes, typically 2 centimeters or less, one lymph node usually. There is almost equivalent outcomes between chemotherapy and radiation therapy for seminoma. There's some ongoing RPLND data growing in this field. And for non-seminomas, chemotherapy and RPLND have about an equivalent or close to an equivalent cure rate as single treatments. When we get into stage 2B, these are greater than 2 centimeters worth of lymph nodes or multiple lymph nodes in the retroperitoneum. There's much more balance between chemotherapy and surgery. Surgery will only cure about 50% of men who have stage 2B non-seminomas. And finally, when we get into stage 2C disease, these are lots of lymph nodes or really big lymph nodes. We know that those men are going to recur if they undergo surgery or radiation therapy. So these men are treated with chemotherapy almost exclusively. And lastly, stage 3 disease. This is distant metastatic disease. The goal is to cure here at all costs. So your urologist or your oncologist is often going to be talking to you about chemotherapy. They may be talking about multimodal treatment approaches, meaning chemotherapy and a retroperitoneal lymph node dissection, making sure that we get to cure at all costs here, knowing that we still will cure the majority of men, but survival is much more guarded for men with stage 3 disease than it is for men with stage 1 or 2 disease. I hope you find that helpful. Thank you for listening, and good luck on your journey.